Hello, I'm Dr. David Liu, and I'm here to describe to you a unique service we offer at UCLA on liver tumor ablation. For starters, I'm an abdominal radiologist specializing in both diagnostic imaging as well as interventional radiology, but only in the abdomen. I dedicated my career to develop advanced imaging techniques as well as interventional tools for the minimal invasive eradication of solid cancer without open surgery. And the most important and the most common of these procedures now performed within the liver for liver tumors. So let me just show you by example how this procedure works. This is a MRI showing a small tumor identified in the left lobe right here. And because we can see it, and we have dedicated tools that can access these small lesions, in this case, just a tiny needle that we can place precisely into the tumor. What we can do with that is, in this case, inject absolute alcohol, 99% proof alcohol, which will kill anything in its way, and in this case, has completely killed the tumor. So as you can imagine, if you can do this, then you can do anything with the tumor, injecting all kinds of different agents, right? But in this case, we were able to see this small tumor based on MRI and CT. We have other tools that we can use for targeting tumors. For example, in this case, we're using dedicated real-time ultrasound where we can advance a needle directly into this tumor. And you can see how things actually move during the procedure. And this technique allows us to see in real time what structures to avoid and how to navigate directly into the tumor. What we want to achieve in the end is this. This is an MRI after an ablation procedure which shows this tumor completely surrounded now by this, what I call the white zone, which tells us this is burned tissue with the tumor itself sitting inside of it. Interestingly, you can see how the tumor itself shrunk because this tumor was literally burnt or incinerated. And that's what we like to see. So coming back to getting the ability to get a needle directly into the tumor, if we can do that, we can inject a number of toxic agents, not just ethanol, but we can use direct chemotherapy, and we can use gene therapy and now immunotherapy to effect cure for these tumors. But also we can use energy-based devices and use radio frequency or microwave or laser, but they all achieve the same thing. They heat up the tumors. Or we can use cryoablation where a needle actually freezes the tumor, right? Both can achieve the same thing, killing cancer cells. Or we can apply literally electric shock therapy. We call it IRE or irreversible electroporation. And these can also kill cancer cells. But the principle is the same. We must get the needle probe precisely where we need within or surrounding the tumor. So with this technology, what can be treated? In essence, any liver tumor that traditionally can be surgically removed and benefit the patient, if for whatever reason it cannot be removed due to medical reasons or other reasons, then we can do this therapy without having to go through open surgery. And the prototype and the most common scenario is the primary liver cancer or bile duct cancer or any metastatic tumors from other primaries. And regardless, as long as we can identify the lesions, we can find them, we can target them and treat them. In general, the lesions cannot be too large. I would say a reasonable cutoff is about 5 centimeters. And there cannot be too many of them. And a reasonable cutoff may be up to 3 for this type of procedure. But of course, they also have to be technically safe and accessible. And this is primarily determined by imaging. So very importantly, we have to have the right imaging to tell us whether this procedure is feasible or not. The time course for this type of procedure, first of all, it's outpatient based. So you come in the morning and go home the same day, or come in the afternoon and probably stay overnight. In either case, this is an outpatient based procedure. And before the procedure, obviously, we review the imaging, the labs, any anesthesia clearance that's necessary. And on the day of the procedure, the anesthesiologist will walk you through the anesthesia care that needs to be delivered. After the procedure, and recovery is typically 6 hours, and discharge either the same day or the next day. The procedure itself lasts anywhere from 2 to 3 hours. And after the procedure, when you go home, there might be mild to moderate pain for a few days. I would say many patients don't even require any pain medicine, but that's not unreasonable. And there may be fatigue and sort of a general flu-like symptom for a few days, up to a week. And that's about really it. And we follow you at a predetermined time point at 1 month, 3 months, 6 months, 9 months, and 12 months for the first year. And this is really to make sure that we've achieved what we want to achieve and no tumor actually comes back. And if we can find a tumor that does recur, we want to find them early so we can do what I call a touch-up and actually maintain that tumor-free status. And there's another example of what we like to achieve. This is, again, liver cancer that has developed and was caught early on, so it's a small tumor. Very deep inside the liver, so this would have required a major surgery to get to. But if we can get a simple needle into this thing, we can burn it with the result looking like this. Again, that white burnt zone completely covering the tumor itself. And in this case, we monitor religiously to determine no recurrence. And in this patient, not only was there no recurrence, the entire tumor and the scar tissue completely disappeared after 6 years. Yes, this is what we would like to see. In terms of complications, as you can imagine, it is an interventional procedure, so complications are possible, but far, far less than open surgery. And the type of complications that might happen are typically some mild bleeding, maybe infection, and of course we like to avoid all the other injuries, but these are often unexpected and cannot be prevented. And the key point here is that these are rare. So why would you want to come to UCLA for these procedures? And I think being one of the first to start this procedure in the United States, we're now one of the largest volume centers. And in fact, we perform over 500 of these procedures a year now, and the majority of which are liver-based. And because we do so many, we actually have now dedicated experts in each of the body areas. So I'm a liver ablation specialist, and we have other interventional radiologists who are subspecializing in lung tumors, and other interventional radiologists who specialize in kidney cancer. And not only that, when it comes to the liver, we also have a very comprehensive program involving not just the interventional techniques, but also the surgical techniques and the oncology techniques and the radiation therapy techniques. And we have tumor boards that discuss these tumors to find the best course of action for each patient. And we also have dedicated interventional radiologists who perform not just tumor ablations, but other interventional procedures such as chemoembolizations, radioembolizations. And I think this is the type of comprehensive approach that in the end would have the best outcome for the patient. Thank you.